Welcome to MedScroll Clinical Case Files, where we bring real-world complexity into sharp clinical focus, one long case at a time. In this second episode, we meet Ms. Isabella Grant, a 53-year-old woman navigating the challenges of limited cutaneous systemic sclerosis, also known as CREST syndrome. Her case unfolds across multiple systems, from recurrent digital ulcers and calcinosis cutis to gastroesophageal reflux, oesophageal dysmotility, and the serious complication of pulmonary arterial hypertension confirmed on right heart catheterization, with a constellation of symptoms that impacts her mobility, nutrition, and quality of life. Ms. Grant's journey offers a deep dive into the interdisciplinary care and clinical reasoning required in complex autoimmune disease. Join us as we walk through her full RACP-style long case presentation, from clinical formulation to examiner discussion, model responses and reflections on patient-centered care, symptom control, and function-focused management. So, grab your stethoscope and let's explore the interplay between pathophysiology and lived experience in systemic sclerosis.
Good morning. I would like to present Miss Isabella Grant, a 53-year-old European woman with a diagnosis of limited cutaneous systemic sclerosis, CREST syndrome, complicated by pulmonary arterial hypertension, PAH, recurrent digital ulcers, calcinosis cutis, and esophageal dysmotility, with gastroesophageal reflux disease, GORD. She also has well-controlled hypertension, hyperlipidemia, and osteopenia. Her condition has had a significant impact on her hand function and exercise tolerance, with consequences for her quality of life and occupational engagement. Ms. Grant first developed Raynaud's phenomenon at age 42, which was followed by non-healing digital ulcers and telangiectasia. She was diagnosed with CREST syndrome at age 45 after nail fold capillaroscopy showed a scleroderma pattern and anti-centromere antibodies were detected. At age 48, she developed progressive dyspnea on exertion. An echocardiogram showed elevated right ventricular systolic pressures, and right heart catheterization confirmed PAH with a mean pulmonary artery pressure of 30 millimeters of mercury. She is currently managed with ambrisentan, 5 milligrams daily, and sildenafil 20 milligrams 3 times daily, with partial symptom control. Her digital ulcers recur, particularly in colder months. They are managed with nifedipine 30 milligrams daily, iloprost infusions during flares, and wound care support. She has extensive telangiectasias on her face and chest, and calcinosis cutis affecting the fingertips and elbows, causing discomfort but no active infection. Her GORD with esophageal dysmotility is managed with omeprazole 40 milligrams daily and lifestyle modifications. She reports intermittent dysphagia for solids. Hypertension, well controlled on perindopril 5 milligrams daily. Hyperlipidemia, managed with atorvastatin 20 milligrams noctate. Osteopenia, diagnosed on recent DEXA scan, T-score negative 1.9, treated with calcium and vitamin D supplementation. Depression, previously treated, currently stable without pharmacotherapy. She has no history of diabetes, coronary artery disease, or interstitial lung disease. Ms. Grant is divorced and lives alone in an independent apartment. She has 2 adult daughters living interstate with regular contact. She works part-time as an administrative assistant, but reports significant difficulty with fine motor tasks and fatigue impacting her work attendance. She is a non-smoker and drinks alcohol socially, 1 to 2 drinks per week. Psychosocially, she expresses frustration regarding her functional limitations and acknowledges concern about disease progression, but remains engaged in her care. Thin, well-groomed female, appears her stated age, BP 128/76 millimeters of mercury, heart rate 82 beats per minute, respiratory rate 18, temperature 36.8 degrees Celsius, Oxygen saturation 96% RA. No cardiac murmurs. Normal JVP. No peripheral edema. Clear breath sounds. No crackles. Abdomen soft and non-tender. No organomegaly. Sclerodactyly with digital pitting scars and an active ulcer on the right index fingertip. Telangiectasias on face, chest and hands. Calcinosis nodules over elbows and fingertips. Nail fold capillary dropout with dilated loops. No synovitis. Normal joint range of motion. Neurologically intact, including cranial nerves, tone, power, reflexes, and sensation. Ms. Isabella Grant presents with CREST syndrome, complicated by pulmonary arterial hypertension, World Health Organization class 2 to 3, recurrent digital ulcers with Raynaud's phenomenon, calcinosis cutis, oesophageal dysmotility with GORD, hypertension and hyperlipidemia, osteopenia. These comorbidities contribute to functional limitation, pain, and psychosocial strain, necessitating a coordinated, multidisciplinary approach. Pulmonary arterial hypertension. Continue ambrisentan and sildenafil. Monitor with 6-minute walk tests, BNP levels, and echocardiography. Referral to pH specialist if deterioration occurs. Raynaud's phenomenon and digital ulcers. Continue nifedipine and iloprost infusions during flares. Emphasise hand warming and wound care. Consider bosentan for refractory ulcers. Calcinosis, cutis. Symptomatic management with analgesia and local steroid injections as needed. Monitor for secondary infection or ulceration. Oesophageal dysmotility and GORD. Maintain omeprazole therapy. Dietary advice and consider prokinetics if dysphagia worsens. Hypertension and hyperlipidemia. Continue perindopril and etovastatin. Monitor BP and lipid profile annually. Osteopenia. Continue calcium and vitamin D supplementation. Repeat DEXA scan in 2 years. Consider FRAX assessment and osteoporosis clinic referral if fracture risk increases. Psychosocial and functional support. Occupational therapy for hand function and workplace adaptations. Offer psychological support if mood issues recur. Social work input for community resources and workplace liaison. This case highlights the multisystem burden of CREST syndrome, with pulmonary hypertension and digital vasculopathy being the key drivers of morbidity. Ongoing multidisciplinary care is essential to optimise outcomes and maintain quality of life.
What features help differentiate limited cutaneous systemic sclerosis, CREST, from diffuse systemic sclerosis, and what are the implications for prognosis?
Limited cutaneous systemic sclerosis, also known as CREST syndrome, is characterised by skin involvement, distal to the elbows and knees, often including the face and neck, without proximal limb or trunk involvement. The acronym CREST stands for calcinosis, Raynaud's phenomenon, esophageal dysmotility, sclerodactyly, and telangiectasia. This contrasts with diffuse systemic sclerosis, where skin thickening involves proximal limbs and trunk, and is associated with early and more aggressive internal organ involvement, including interstitial lung disease and renal crisis. In terms of prognosis, CREST has a slower disease progression and lower mortality compared to diffuse disease. However, pulmonary arterial hypertension, PAH, which is more commonly associated with limited cutaneous systemic sclerosis, remains a significant cause of morbidity and mortality.
Describe the pathophysiology of pulmonary arterial hypertension, PAH, in systemic sclerosis and outline your approach to its management.
In systemic sclerosis, PAH results from vasculopathy of the small pulmonary arteries, leading to endothelial dysfunction, vascular remodeling, fibrosis, and intimal proliferation. There is an imbalance between vasodilators, e.g., nitric oxide prostacyclin, and vasoconstrictors, e.g. endothelin-1, favouring vasoconstriction, and smooth muscle proliferation. Diagnosis is confirmed via right heart catheterisation with a mean pulmonary artery pressure greater than or equal to 25 mm of mercury, and a pulmonary capillary wedge pressure less than or equal to 15 mm of mercury. Management includes endothelin receptor antagonists, e.g. ambrisentan, phosphodiesterase 5 inhibitors, e.g. sildenafil, prostacyclin analogues or receptor agonists if disease progresses, regular monitoring with 6-minute walk tests, BNP levels, and echocardiography, referral to a pulmonary hypertension specialist centre if deterioration occurs.
How would you monitor disease progression in systemic sclerosis, particularly with regard to pulmonary complications?
Monitoring focuses on early detection of complications, such as pulmonary arterial hypertension and interstitial lung disease, ILD. My approach includes pulmonary function tests every 6 to 12 months, particularly focusing on DLCO, which is sensitive for early PAH, echocardiography annually or sooner if symptoms worsen, assessing right ventricular systolic pressures, right heart catheterisation for definitive PAH diagnosis, and monitoring response to therapy, high-resolution CT chest if ILD is suspected, clinical assessment of dyspnea, fatigue, and exercise tolerance via 6-minute walk tests.
What are the pharmacological and non-pharmacological options for managing Raynaud's phenomenon and digital ulcers?
First-line pharmacological management involves calcium channel blockers such as nifedipine, which help reduce vasospasm. Other options include phosphodiesterase 5 inhibitors, e.g. sildenafil, endothelin receptor antagonists, e.g. bosentan, particularly for recurrent digital ulcers, prostacyclin analogues, e.g. iloprost infusions during severe flares, non-pharmacological measures, hand-warming techniques, thermal gloves, hand warmers, smoking cessation, although this patient is a non-smoker, stress reduction, local wound care with involvement of a wound care nurse. In refractory cases, surgical options such as digital sympathectomy may be considered.
What is calcinosis cutis, and how is it managed in the context of systemic sclerosis?
Calcinosis cutis refers to the deposition of insoluble calcium salts in the skin and subcutaneous tissues, commonly seen in systemic sclerosis, particularly in CREST syndrome. Management is challenging and largely symptomatic local wound care for ulcerated lesions, analgesia for symptomatic relief, intralesional corticosteroids for smaller painful nodules. Rarely, surgical excision if calcinosis leads to recurrent infection or significant functional limitation. Emerging therapies may include bisphosphonates or sodium thiosulfate. Though evidence remains limited, rheumatology follow-up is important for monitoring progression and assessing the need for escalation of therapy.
Outline your management of esophageal dysmotility and gastroesophageal reflux in systemic sclerosis patients.
Esophageal dysmotility in systemic sclerosis is due to smooth muscle atrophy and fibrosis, leading to decreased lower esophageal sphincter tone and impaired peristalsis. Management includes proton pump inhibitors, e.g. omeprazole for acid suppression, lifestyle modifications, head of bed elevation, avoiding late meals, small frequent meals, weight management, prokinetic agents, e.g. metoclopramide, if symptomatic dysphagia or delayed gastric emptying is present. Monitor for complications such as Barrett's esophagus or aspiration.
How do you assess and manage cardiovascular risk in patients with systemic sclerosis, particularly with coexistent hypertension and hyperlipidemia?
Systemic sclerosis patients have an elevated cardiovascular risk due to microvascular dysfunction, systemic inflammation, and endothelial damage. Assessment includes regular BP monitoring, lipid profile annually, cardiovascular risk stratification tools, with awareness that standard calculators may underestimate risk in systemic sclerosis. Management antihypertensive therapy, e.g. perindopril, targeting blood pressure, less than 130 over 80 millimeters of mercury. Statin therapy, e.g. atorvastatin for lipid control. Encourage lifestyle changes, diet, exercise, smoking cessation. If applicable, consider low-dose aspirin if high cardiovascular risk without contraindications.
What factors would lead you to consider escalation of pulmonary hypertension therapy in this patient?
Escalation of PAH therapy would be indicated by worsening WHO functional class, progression from 2 to 3/4, decline in 6-minute walk distance, rising BNP or NT, pro-BNP levels, deterioration on echocardiography, e.g., increasing right ventricular systolic pressure, right ventricular dysfunction. Symptoms such as syncope or progressive exertional dyspareunia. If these occur, referral to a specialist PAH centre for consideration of combination therapy or prostacyclin analogues would be appropriate.
What is the impact of systemic sclerosis on Isabella's daily functioning and occupational engagement, and how would you assess this?
Systemic sclerosis, particularly CREST syndrome, can significantly impact daily function through symptoms like Raynaud's phenomenon, digital ulcers, calcinosis, and breathlessness from pulmonary hypertension. Isabella's hand involvement contributes to difficulties with fine motor tasks, including typing and household chores, while dyspareunia limits her exercise tolerance. Assessment would involve direct history taking, focusing on activities of daily living, ADLs, and instrumental ADLs, occupational assessment of workplace limitations, e.g. typing difficulties, time off for medical care, screening for fatigue and pain, both of which influence work capacity, collaboration with occupational therapy to formally evaluate hand function and recommend adaptations or assistive devices.
How would you communicate the importance of pulmonary hypertension monitoring to this patient while balancing optimism and realism?
Effective communication would involve clear, jargon-free explanations of PAH as a serious but manageable complication of her condition. I would emphasise the rationale for regular monitoring with echocardiography, 6-minute walk tests, and blood markers BNP, how early detection of deterioration allows timely intervention, which improves outcomes. Acknowledge her concerns and validate her lived experience. Maintain a positive but realistic tone, reinforcing that although PAH can progress, there are multiple treatment options available. Encourage shared decision-making and offer written information or referral to a PAH nurse educator if appropriate.
Discuss your approach to pain management and quality of life support in a patient with calcinosis cutis and digital ulcers.
Pain from calcinosis and digital ulcers can be both physically and psychologically distressing. My approach includes analgesic ladder approach starting with paracetamol, considering cautious use of NSAIDs with monitoring due to cardiovascular risk, and adjuvant agents such as amitriptyline if neuropathic pain features are present, use of iloprost infusions during ulcer flares to promote healing and reduce pain, local wound care with a dedicated wound care nurse, non-pharmacological strategies, including hand protection, avoidance of trauma, and thermal gloves. Consider psychological support or pain clinic referral for chronic pain coping strategies if needed.
How would you approach counselling regarding family planning, contraception, or hormone therapy in women with systemic sclerosis?
Key considerations include thorough assessment of reproductive goals and family planning wishes. Highlight the risks of pregnancy in systemic sclerosis, particularly in the presence of PAH, where pregnancy may be contraindicated. due to high maternal mortality risk. Counsel on effective contraceptive options, prioritising non-oestrogen containing methods due to thrombosis risk. Review current medications for teratogenicity, e.g. endothelin receptor antagonists are contraindicated in pregnancy. Hormone replacement therapy may require careful risk-benefit analysis, considering cardiovascular and thrombotic risks. Coordination with rheumatology and high-risk obstetrics for pre-pregnancy counselling if pregnancy is considered.
What supports would you offer this patient to address psychosocial strain and potential mood disturbance related to chronic illness?
I would take a holistic approach to psychosocial care by actively screening for depression and anxiety, using validated tools such as the PHQ-9 or GAD-7, encouraging referral to a psychologist or counsellor for cognitive behavioural therapy, CBT, or supportive therapy, suggesting peer support groups for patients with systemic sclerosis or chronic illness, involving social work to explore financial supports, workplace accommodations, and access to community resources, emphasising regular follow-up to review psychological well-being over time.
Outline how you would coordinate multidisciplinary care for this patient. Who are the key team members?
A multidisciplinary approach is essential in systemic sclerosis management. Key team members include rheumatologist for systemic disease management, pulmonary hypertension team, including cardiology and respiratory physicians, GP for coordination of care and chronic disease management, wound care nurse for digital ulcers, occupational therapist for hand function and workplace adjustments, physiotherapist for maintaining mobility and preventing deconditioning, dietitian for nutritional support, particularly regarding dysphagia, psychologist and social worker for mental health and psychosocial support. Regular communication between team members, potentially via case conferencing, is crucial for optimizing outcomes.
What lifestyle modifications would you recommend to optimize health outcomes in systemic sclerosis?
Lifestyle advice would include smoking cessation, although Isabella is a non-smoker, hand warming strategies and avoidance of cold exposure, balance low acid, soft diet to manage oesophageal dysmotility, regular physical activity with intolerance to prevent deconditioning and maintain cardiovascular health, skincare to reduce trauma risk and prevent infection, stress reduction techniques to minimise Raynaud's flares.
How would you ensure adherence to a complex treatment regimen for systemic sclerosis and PAH in the context of multiple medications?
Strategies to support adherence include providing clear education about the purpose, benefits, and side effects of each medication, simplifying the regimen where possible, using combination therapies or once-daily dosing if available, engaging the pharmacist to provide blister packs or dose administration aids. Regular follow-up to review medications and address side effects or barriers, involving family or caregivers with consent to support adherence, checking for financial barriers and linking to support services if needed.
Ms. Isabella Grant's case is a vivid reminder that autoimmune diseases like systemic sclerosis don't just affect organs, they reshape lives. From the management of digital ulcers and pulmonary hypertension to navigating dysphagia, pain, and occupational limitations, her story highlights the importance of holistic, multidisciplinary care, where rheumatology, cardiology, gastroenterology, and rehabilitation medicine all intersect. If you found this episode insightful, don't forget to like, subscribe, and hit the bell icon so you never miss an update. Drop a comment below with your thoughts on the case, what you'd do differently, or what topics you'd like us to explore next. This is MedScroll, bringing clinical complexity into focus, one case at a time. See you in the next episode.